of past medical history, how, the overlay of homelessness, housing insecurity, as well as a history of incarceration, the health effects overall. So I think before we get started, I can't tell from here, are most folks here medical students or maybe residents, or where people's, maybe you could throw it in the chat, or if you want to like update your name or something like that, just so I have an idea like regionally where people are from. We happen to be in New Haven. Um, so anyway, I did graduate from University of Miami for medical school, so shout out to Dan. Um, I love the U, but anyway, yeah, that's just like also for us to understand a little bit of, you know, your level of interaction and all that kind of stuff too. So I do see a nice diversity. But anyway, Kate, any other things, or we just get started or what? I don't
No, let's boogie. We got a lot to cover.
know. Okay, so really, this is what we're talking about today. Um, so that intersection we spoke about earlier, and really trying to separate it a little bit. So what incarceration could mean for someone's health, a history of incarceration, or even like what happened during incarceration, and then that overlay with homelessness as well, and then just like the best way to care for our patients. My personal experience is I did work in the jails at some point, and so I have like knowledge of like how the healthcare is inside, but then also kind of working with transitions clinics and their care outside. So there'll be a lot of data and information. Some of this is important or not important, but known. So this is just purely by numbers, right? So we have big numbers here. Um, but then when you look at percentages, this is street, right? So this is actually, so you might have a big number like in Oregon, but a majority of those individuals are not housed, not in a shelter situation, in an unsheltered situation. So this is really, again, this is the Street Medicine Institute, right? How does that overlay with incarceration rates, right? So when you're looking at this, hi, Dr. Howell, also part of our Yale Street Medicine training program. So please jump in at any time. We kind of worked on this with a bunch of different information. Dr. Howell is also at the Yale Primary Care Residency, addiction medicine physician as well, and part of the SEICHE Institute, as we mentioned earlier.
Yeah,
But
sorry
really,
for
this
running late.
over,
Thanks, Jeffrey.
I think it's the overlay, and we can just look, right? So you have your street unsheltered homelessness. You also have, this happens to be the highest rates of incarceration in certain areas, right? So you can kind of look at some patterns and stuff. We happen to be here in Connecticut, so wherever you folks are coming from, you can see a differential. And just to look at what the problem is, this is, let's just say it's not a US problem, but just looking in comparison to what the US looks like. These are rates, right? 614 per 100,000 compared to all the quote unquote industrialized nations that we like to compare ourselves against. Right? So you could just see a huge difference in who's in, let's say, how many people are imprisoned. And just the way to think about it, just for big numbers' sake, it's about 2 million folks in at any given moment. Okay. Whether they're in prison, whether they're in jail, and we'll go over the differences later. There's different forms of custody. We now have a big slice that's immigration detention and ICE. And this also has just a massive breakdown. So you can really see a lot of the data and slides here from the Prison Policy Initiative. Um, in general, are folks familiar a little bit with jail versus prison? When someone says that, anyone know that or understand that or have an understanding? Or would like to share their thoughts? Or not. But the idea being jail is really short term, right? But short term could still be a long time. Um, it really is meant to be sort of holding, right? So let's say someone's arrested, they actually are not indicted. They don't have a sentence or anything like that. They might still are awaiting some kind of trial, or maybe they couldn't pay their bail because it was something smaller. So either way, people still end up in jail, and they could end up in jail in a long time. And this just to be compared to someone who, let's say, was sitting in jail for a couple of weeks, had their trial, was sentenced, and therefore is now in prison. And then prisons can be federal prisons or state prisons. And just there is a difference here. And just to say, when I was working in the jails, we actually had people working for a very long, who were staying in jail for a very long time because the prisons were too full, or they were like a low security need on a prison on a patient with a long sentence, and so we're living in the jails. And so this is just that same kind of data, just to keep in mind. So
Jeffrey, can I
yeah,
chime in? Can you go back to 2 slides to the pie? So yeah, just so people appreciate, I mean, this is a cut in time. So this is at any given time, there's about 2 million people behind bars. I think this underemphasizes the role that jails have, especially for the population that's unhoused. This is one point in time, but many more people come in and out of jail in any given year. I forget the exact number, but it's going to be a couple orders of magnitude of the number of people exposed at any one given time just because of the high turnover. And the average amount of time someone spends in jail is like 3 days at most. Like that's the average. Obviously, there's some people, as Jeffrey said, who are much longer, but a lot of people much shorter. And that disruption can have a lot of impact on people's health. And you can imagine, Jeffrey, we're going to talk about this a little bit, but the population that's unhoused, they're going to be going in and out of jail all the time on low-level offenses. And that impact is much larger than is probably appreciated by this sort of cut-in-time pie.
yeah, yeah, and then a bunch of information, but essentially the idea is, so just keep this kind of figure in mind. So we have about 2 million folks in jail at any given moment. Out of that population, uh, let's go back to this number here. So overall, this is like the U.S. rate, right, of homelessness, right? It's like 22 out of 100,000. And so the individuals who are in jail, there's going to be a much higher rate of people who are unhoused, and we'll go through some of the figures there. And so therefore, if it's only 0.22%, but it's 5% are unhoused, you have a much higher rate of homelessness among incarcerated individuals. And then also a much higher rate of unemployed status of individuals who are incarcerated versus in the general population. And so all those kind of socioeconomic kind of trends play out. It plays out in who happens to be in jail, right? Or incarcerated, right? So this is different categories, but for people of color, so this is the general homelessness rate, right? 21 out of 100,000. But if you're prior incarceration, it's that 25 times higher. So 200 individuals out of this number are going to be with homelessness. And you can see higher numbers for individuals who are women, higher numbers for individuals of color in comparison. So again, this is like that general population, and this is an incarceral population. And that similar issue that Dr. Howell mentioned, that population that's coming into jail, right? So this figure tells us that there already was a high degree of homelessness before going to jail, before going to prison. And so that revolving door issue is that someone who ends up incarcerated, may lose their housing in that process, and then coming out, where are they coming back to? So I think this is like just showing you the extent of the problem. Ben, was there anything else on this? Or this was pretty much it?
No, that's good.
Yeah. And then again, these figures, right? And you can see all of this. So this might be your kind of similar to the slide we showed earlier, but multiple incarcerations, multiple periods, you're going to have a much higher rate of homelessness compared to perhaps incarcerated only once. And it also leans relatively older, right? So the older folks who happen to be incarcerated also have a higher rate of homelessness. So you can see these are all just differentials. And then just for that same kind of data, right? So you have, and this makes, I don't want to say it makes sense, but I want to say it contributes, because if you're unemployed, then you're not going to have, the money resources to get stable housing. And if you're incarcerated, you might have a harder time to become employed. And so you really end up in a very difficult situation. And so with the Transitions Clinic Network and a lot of work with people who are working with individuals outside of incarceration, it's trying to get access to those services, to get access to employment, to find the right types of employers who don't have any bias or prejudice or anything along those lines. And then again, just this same thing here, right? So your unemployment rates are going to be much higher, right, for somebody, over 40% who had incarcerated versus not incarcerated, right? So even if you're not incarcerated anyway, never had a prior incarceration rate, there is a differential no matter what, but you can see much higher numbers. It's almost like magnified. And then even if you end up, with a full-time job, with any kind of employment, there's a differential between the person who might have that full-time job with employment and benefits and stable salary, etc., versus people who again are unemployed, and even so, differential when you look at like who's part-time work, right? Because again, that part-time work, getting just under the number of hours that would give somebody benefits, for example. I mean, these are all very high. This is just the reality. This is just like how our systems have played out and kind of led to some of these situations. So this again, same thing, multiple housing. So Dr. Howell, I think this was kind of what you were speaking a bit more about, the multiple bookings, multiple times in and out of jail. And so you're going to have a much higher rate of people with multiple bookings being completely unhoused versus maybe it was just a one-time thing. And so like a random crime, then they'll have a higher rate of housed. Maybe this piece right here, if you want to speak on this, Dr. Howell, kind of what this criminalization of homelessness and kind of the context of this.
Sure. I mean, probably many people on the call are aware of this change in the recent years. I mean, when 3 years ago, if you asked sort of any jurisdiction if they could sort of put someone in custody related to sort of just being street homeless, just having no place to stay, whether they were encampment or something, the prevailing law of the land was not okay. Like that was against the law to sort of put someone in custody just based on their housing status. That unfortunately changed. The city in Oregon, Grants Pass, sort of brought a case all the way to the Supreme Court. And the Supreme Court sort of changed precedent at that time, that saying that historically, as I said, that was not the case, that precedent got changed, and now that sort of jurisdictions could sort of put people in custody just based on sort of being street homeless or sort of being encampment. It was a big change, and this is not like a blue state, red state thing. So of course, Oregon is a blue state. Many sort of blue cities, if you will, San Francisco is one example. Have really taken this up, or LA is another example of taking this up as an opportunity to quote unquote sort of manage some of the issues they're having with the street homelessness. More recently in the news, Louisiana is about to put a state law in place that would similarly sort of enshrine in state law in Louisiana that people could be incarcerated just based on being street homeless. I don't know if Jeffrey, is there anything else that you wanted to add upon this?
Yeah.
Honestly, it's just going to reinforce sort of the criminalization and sort of this revolving door between incarceration and homelessness.
And Louisiana already had the highest rates, which is crazy. Has anyone on the call seen or can think of like that, what that criminalization looks like when you're working with people living on the street? Like, has anyone seen like examples of charges and things?
I was gonna say like trespassing is a super common one. And then also like there's kind of like a soft criminalization where of course if you're outside, there's more eyes on you. People are a lot more likely to call the police on you and then get caught for something else that somebody who wasn't in that situation wouldn't have been caught for.
I think Danielle had a hand up, I think.
Yeah, I'm in Knoxville, Tennessee, Knox Street Medicine Outreach, and our when our city has been enforcing this, it's apparently it becomes a federal charge. It's enforced as a federal charge versus a state local charge.
Okay.
So you get that being on your record, it really becomes even more difficult to gain employment with that charge on your record.
Yeah, I think what Nima mentioned also just this like existing outside, right? Not having that privacy. So hey, you might have whatever activities, that illegal or not, right? You don't have that privacy anymore. And there's also a lot of these, and this is, something that's probably been discussed here too, is like these kind of reporting websites, right? So citizen reporting websites like see something, click something, or any kind of given things like that. It's meant to be like, okay, yeah, these are there's a broken street light or a broken traffic light or whatever. But these kind of things have also been weaponized, right, against individuals, against encampments, against to really like put a GPS right onto some site, right? And so these kind of like public, I don't know what you call these, like public surveillance reporting mechanisms, highly prevalent. So yeah, just to go back to some of the typical charges, right? So they are majority nonviolent, trespassing, as we mentioned, some of this like public urination, indecent exposure. There's no restroom, right? And so somebody might need to urinate, and and all of a sudden that turns into indecency charge. So a variety of nonviolent crimes, and so we can even see here, just by breakdown, that the violent or quote unquote violent crimes, there's going to be a lower rate, right, compared to kind of average versus unhoused, right? So you can see the violent crimes are lower, and so yeah, I mean this is just kind of the demographics. And so in speaking about this housing implication, right, if you do have that record and you're trying to apply for some kind of housing, we know that a landlord, they're not supposed to have any sort of um, ask some of these sorts of questions, but it may still come out in a background check. And at the end of the day, a landlord may just come up with whatever reason they want to say for somebody. He says, "Oh, you didn't pass whatever," but certainly there's a lot of difficulty for people coming out of incarceration to find housing, and not just housing, but also employment as well. So one thing that we've been dealing with here in New Haven is this like proof of homelessness. So even someone who might have been otherwise, I don't know, in a jail or somewhere else, I guess they have to show that they were somewhere else and not housed uh, in order to maintain that they were actually homeless, versus saying, hey, you were like technically housed because you were in a facility, right? So just imagine the difficulty there. So just in general, homelessness this is, we're speaking to SMISC here, but I think when we talk about healthcare and different sorts of kind of how we would have our health contacts, I think part of it is like the screening problem, right? It's like, because we don't always ask if individuals are homeless. And now in street medicine, we know that's the case, but in any given clinic, even if you're working with patients who happen to be admitted in the hospital, they're in the emergency room, you may not know what their status is. So it's always just number one, to just important to ask that question. And then ourselves here, we've been trying to work on transitions of care, and this is a hot topic, of course, in street medicine as well. How to get the appropriate kind of follow-ups for individuals who are unhoused. So anyway, this was like a wrap. I think the next section is going a little bit more specifically into incarceration itself and the kind of experience of incarceration and the healthcare within incarceration. So just a question for you all, how, these are just some terms, but what do you all think about like different terms, different phrases, Is this prison medicine? Is this justice involved? I mean, there's many different terms. Any thoughts on some of the names that you're seeing here or ways to talk about it? I think for me, when I first got a job, you know, I think all my friends or friends from medical school were like, wow, so what happened? Like, why are you working in the jail? Like, that seems like you just, that's for like old, retired, grizzled doctors without empathy or something. And I was like, no, no, that's not necessarily the case. But there is this old stereotype of like the prison doc, the jail doc. And there truly has been like different, different phases of like this type of healthcare or this particular setting. And that's talking about privatization and everything. We'll talk about that. Willow, you had a comment here, criminal justice health. There is, I think what we think about is like, and I've seen this as well, right? Even the biggest place, Academic Consortium on Criminal Justice Health. Does justice have a judgment attached to that, right? Are these individuals unjustly incarcerated even? Or they happen to be in the setting of like I don't know, this like justice orientation. Court involved is interesting because that's very specific. It's like, yes, they've been in court. Um, Correctional medicine is like a whole other thing, and you can see all these other organizations is correctional, meaning or implying like, is there something wrong with these people, right? Because even the idea of incarceration is supposed to be rehabilitation of some sort. What are you rehabbing them from, right? And not to think about individuals who were unjustly incarcerated to begin with.
Jeffrey, I would like to say, I think your point about sort of the perceptions about physicians or other healthcare providers who provide care in correctional settings is an interesting one because there is a huge variety in the quality of care in correctional settings. It is an inherently hard place to practice medicine, and there are still sort of jurisdictions where they do offer sort of substandard care, but there are also some other jurisdictions where there's really kind of a mission-driven ethos to the healthcare that's provided. I mean, for better or for worse, oftentimes that's in more urban locations where people sort of like Jeffrey described one key practice in a jail in LA, or sort of you hear some of the doctors who practice medicine, Rikers in New York. But it is really a variety. And there's this American College of Correctional Physicians is a relatively new entity, and there's sort of a movement towards actually building out a fellowship, sort of ACGME type sort of fellowship for correctional medicine, given sort of the unique sort of environment, with a goal ultimately to increase the quality and recognition of sort of the special skills that are provided to provide healthcare in these settings. But it is a challenging place, and we'll talk about some of the reasons why it's so challenging in a little bit.
Yeah. Yeah. And I think just for myself, I do usually land on healthcare during incarceration, healthcare for just very straightforward. Like that's the fact that happened during incarceration, right? As like a timeline piece. Not that they were corrected during that time, not that they, got justice during that time or somebody else got justice, right? It's just like, yeah, they were incarcerated, right? And so what medicine happened at that time? So that's just me personally. And really thinking about this, I mean, truly, I mean, this was, right? So early on, like healthcare in incarceration, or it was meant to be, therapy, it was meant to be rehab. And really, there were bad periods where there was uh, unlicensed, and even this was even more recently. Like I had colleagues talking about the jails and prisons in Louisiana and how they went, okay, well, they discovered there was a doc who lost their license, etc. But hey, is now like operating, right? But really, I think the main thing that as we move forward was that there was big privatization. There was privatization of the the prison industry itself, and then from there, the healthcare that was inside. Um, and you can see, like back in the 70s, there was very minimal, very minimal standards here. And you can see that here as we move forward in this privatization timeline. These are the kind of the big names that you'll see, right? Centurion is a big one. Horizon is a big one. And these are more national networks that just kind of pop into any kind of given system. They're profit driven, right? So they're not really trying to provide the best healthcare. Um, and so, yeah, this is really like ramped up quite a bit.
I guess they would argue that they are still providing sort of the healthcare, but it is a capitated thing where they bid for these contracts. They get capitated sort of rates per person that's incarcerated. So definitely the incentives are aligned to provide the least amount of care. But there's been a lot of issues that that's funny. This list of names of different for-profit entities, it's kind of an issue where like every couple of years they have to like change their name because they got
Yes.
sued in one state, and then they're like, oh, they were going to recreate this new entity where just all the people move, corporate sort of resources move into a new entity to sort of get out of litigation, which is a big problem. I will also highlight in the 70s, there was a sort of major Supreme Court case that actually, with some irony, sort of one of the few populations in the United States that has constitutionally protected access to healthcare is people who are incarcerated. And due to this Supreme Court decision in the 70s that said it was a Eighth Amendment violation or sort of cruel and unusual punishment to not provide healthcare while people are incarcerated. That ruling was kind of vague on sort of what level of healthcare needed to be provided. So it does mean there's still a lot of variation, but it is, I think, somewhat ironic that one of the few populations in the United States that has constitutionally mandated access are people who are incarcerated.
And then just to ask the group too, has anyone on the call like worked within the jail system or has had a lot of contact? Oh, and then we have a child here too. Okay. Just to understand the room a little bit.
I've done a little bit of work. I'm Sarah. I'm a MD PhD student from University of Nebraska Medical Center. And we've done some work providing free STI testing, specifically to people who are in jail, not individuals who are incarcerated. But specifically also providing harm reduction access to things like naloxone, especially if someone's going to be released from jail soon, knowing that that can be an increased risk for an overdose. So not official employment, but through my
Yeah.
school.
Is it through like a group or how did you all establish that?
Yeah, so it's through a legacy group through the University of Nebraska Medical Center called Do Justice with the STI capitalized in the program, and then Harm Reduction Advocates. And those are both legacy organizations through the university.
Sarah,
And
do you
then
mind sharing? I don't know if this was behind, oh, it sounds like it was actually behind the walls or behind the bars where you're providing this sort of healthcare. What was it like actually? I mean, because I think it's always an interesting, a pivotal experience to experience what it's like to actually go into that setting and provide care. If you mind sharing, what was that like?
I will say it was a surprising experience. To be honest, I was a little bit nervous going into that experience. I'd never, been in any of those experiences before, but I did meet with, there's a really great program in town called Rise, which specifically focuses on supporting people who are reentering the community following especially long-term incarceration. And so I chatted with some of my friends there, was like, hey, gonna be doing this, a little bit nervous. And talking to them really helped me feel a bit better. And then when I went in, I realized that, I think a lot of my nerves and biases, I think were a little bit incorrect. And if anything, I was more stressed and concerned about how a lot of these individuals were, being perceived and treated, especially by the larger community. And, at the end of the day, we're all just people. A lot of people were there for pretty minor, drug offenses. What's the difference between a personal use amount and a like dealing amount? A lot of that, especially in Nebraska, can be up to the arresting officer. What's considered drug paraphernalia again. And I think that actually going to that really kind of flipped the script for me in terms of, I think that more work should be done to educate health providers, regardless of what area you are as a health provider, in terms of what that actually looks like. And there should be more opportunities for students to actually engage with that earlier in your career, rather than later in your career, because it was a pretty transformative experience for me.
Yeah,
Excellent.
thank you for sharing. I mean, I think your experience is both sort of the like difference between what you anticipate and sort of what it's actually like. And people are people, and providing healthcare. I mean, the dynamic is very different, and yet sort of they're just people, so just offering, looking to sort of care for their own health. That one thing that I'm always struck by when I've gone into jails and prisons is that like it's like a loud place. Like it's all cement blocks and glass and metal. There's very little sort of, things to sort of buffer the sound, so they end up being very loud places. Not a lot of privacy, like there's always someone watching. There's clear sort of hierarchy between the people in the jumpsuits, who are the incarcerated people, and then sort of like the other people who are both, correctional officers, and then other professionals like physicians, like nurses, who are coming in to provide, or other teachers you can imagine providing services. And there's clear rules where like certain people can do certain things or sort of follow certain rules. I'm always, it just feels such like an important thing to be like, this is what it's like, even though you're not obviously incarcerated, but you can still get a hint at what it's like to like be in that environment 24 hours a day.
Yeah, there was a lot going on. And I will say, if anything, I think the people that we were there to serve were very kind of rightfully a little cautious of us as well. And I think that that was really important for me to recognize additionally, that, there's a lot going on. As you mentioned, there's very little privacy, and people are rightfully going to be a little bit nervous about being like, hey, yep, let's do this STI testing. Like, while it's free, you know, it's not a super private space.
Thank you, Sarah. Nikki, thank you for asking that question, without making assumptions. So I don't know if there's any positive responses to your question in the chat there, but that would also be a great perspective.
I'll be very blunt and honest. I uh, did go to jail overnight when I was 17. I did not receive health care while I was there. I did have like a screening. But it kind of drove me, I'm a DO student now, at PCOM, but it did drive me to work in a jail for 2 years prior as an EMT. Um, and the experience I had, I really liked what you said about privacy. There was really no privacy there. The doctor was only in twice a week, and it was basically just me and the nurses kind of having him on the phone. He was a great, great provider, and physician. But I will say I was in Boulder County, Colorado, which is a more well-funded jail system than, inner cities. So it was a really tragic experience to see that a lot of individuals prior to jail had no access to healthcare. And it was a little reassuring to see, at Boulder, they did provide medication to everyone, regardless if they could pay or not. I don't think that's the right way for people to get healthcare. But it was moving to see that there can be some systems where people do really truly care.
Megan, I thank you for sharing that. I mean, it is interesting. Number one, it is true that everyone gets screened. Like it's one of the few places where both for mental health and healthcare needs, everyone entering in carceral setting gets screened. And yet, sort of, I think as some people point out, like the access to an actual sort of practitioner can often take days, to sometimes weeks. I mean, usually the typical thing, if you have a need, you have to put in like a sick slip, and then sort of there's a lot of steps in between you putting in a sick slip and sort of actually getting care. Sort of there's like maybe a correctional officer who's sort of weeding that out, or a nurse who's triaging, who may or may not sort of understand the sort of need. And I will say there is people, if it is your first place that you have access to healthcare, that's going to bias the way you think about healthcare forevermore, because you just like you think doctors and nurses are correctional officers or cops, or sort of can conflate the two, and oftentimes people do have negative experiences with healthcare that is depersonalizing and sort of not the best quality. So it has a lot of different overlays.
Okay. Thank you. Did anybody else want to share anything with the group? Dina, you mentioned something in the chat here. So this was during residency. So can you share with us, like, was that a rotation, or was that elective, or how was that?
Hi, yeah, it was an elective rotation that I did. It was at one of the higher security prisons here in Connecticut. It was also at the facility where the people who are screened when they come in and have the kind of highest level of mental health acuity. So whether that's because of suicidal ideation or if that's because of psychotic disorders, get sent there. So it was really interesting. I had some experience in medical school at jails, and so it's very there's there's a lot of like crossover in terms of the populations, obviously, but also very distinct. And I felt like for me, it was really easy, I guess not easy, but it was a lot easier to walk into a jail and working with a lot of people who are there for what I felt like were charges that should have never have happened. Whereas when I was at this higher security prison, you're encountering people who I have a lot more biases towards. So people who might have pedophilia charges, serving life sentences. So that felt very different for me. But it was very, very enlightening, especially as somebody who's going to be working with this population moving forward.
Yeah, I mean, a lot of like important discussions. I mean, the reason I'm asking so much about the experience is, for me personally, I had a rotation, not in medical school, but during residency, which was just like 2 weeks community health, and you go to different places every day. And so I happened, one of the days was in the LA County Jail. And then it was great. And then I just turned that into an elective, and from there, um, employment. And there's certainly, I mean, I don't know that there's a consensus opinion, but for those progressive uh, places where it's not just the grizzled old unlicensed whatever, but it's like someone who's social justice oriented, recognizes a problem, wants to advocate directly with patients in a particular setting. There are some very progressive places with quality healthcare. I mean, patient center medical homes, all the referrals, getting all your USPSTF preventive stuff done. I mean, that could happen. And those places are trying to recruit physicians to come in. So a lot of it is about exposure. So even for you, Sarah, like your fears prior to, because you've never seen it, you might have seen a movie thing or whatever, but um, once you're in, it's not so exotic. And then it's potentially then okay, I can see that this is healthcare. Again, depending on where you're at, right? Depending on where you're allowed access to. And you can see some very progressive, positive things happen within the healthcare system, within a healthcare system. The where I was not a privatized outside corporation. It was like an in-house thing. So anyway, okay. Any other thoughts? Anyone else has been inside in one capacity or another, or wants to share any experiences or what they saw? If not, we can move on.
I did want to share one thing actually, and I think Megan made me feel confident to talk about this. But part of my story, I did peer support before medical school. I'm a person in long-term recovery from addiction, and part of my passion, like I started working with the city council in San Antonio. We're actually doing a like diversion program, and I'm just kind of on the committee to just like give the voice to somebody's lived experience. And it's very much because I did not, get arrested, did not go to jail or what have you that I was ultimately able to get help. I was ultimately able to get into medical school and like dedicate my life to helping other people because there's nothing more antithetical to, at least again with the addiction piece, like there's nothing more antithetical to healthcare than jail or prison. It does the complete opposite of anything that we would ask an addiction patient to do, right? We tell people to go to meetings, we tell people to find community, go get a job, find, what is worth being sober for. And there's nothing that can quite destroy all of that overnight than, having this label of being, a felon or even just a misdemeanor and all the things that comes with it. And it completely blows my mind, honestly, that they just really work in complete opposite to each other. And I feel very fortunate that, that was not my story and it could have been, I could be a very different person today. But I just kind of when I see the juxtaposition of healthcare and prison, I mean, obviously, people have like healthcare needs in prison and they should be treated, and also like acknowledging just how much damage it can do in certain cases. That's just so antithetical to any kind of treatment that we would think about.
Yeah, great. Thank you. Um, okay. again, thank you everybody for sharing. So interesting things about access, about paying, somebody mentioned. So there's states where, hey, you're charged for that visit, for submitting that sick slip, for going to the clinic, which is wild. But anyway, that's a reality currently.
But Jeffrey, I will note that this map is out of date. Connecticut actually just did pass a law that the copays are going to be removed in Connecticut. So there is a movement to sort of undo this. I mean, Nevada, actually, it's fascinating. I mean, I think Nevada has changed recently because Nevada had some really bad abuses of copays. Could you imagine sort of like what sounds like an innocuous copay, like $5 or something, but for someone who the people who are able to make wages in prisons or jails is oftentimes much, much, much below sort of minimum wage on the order of pennies. And so like it takes literally a month or 2 months of work to pay for one copay. So it is a real big barrier to access to care.
Yeah. The question about are people even insured coming into prior to incarceration, right? So let's just say this is truly an average number. This back in 2016, this was like, hey, the launch of the Affordable Care Act and everything like that. Pretty high, okay? But still, the individuals, you're going to have half that number of individuals who happen to be in prison. Half of them will have the health insurance, right? And so there's just that differential. Again, all the point of all this data is to just point out the differentials. And then in general, looking at what the healthcare conditions are. And again, I think the framework, and we'll get to the framework later, is the health of individuals prior to incarceration. So it's not even like a pre-incarceration, but let's just say a population that may end up in jail, what their health kind of history looks like. And then what happens in jail, all the health aspects of being incarcerated itself. And then coming out of jail, what are the implications of trying to access healthcare with all that. So just have that framework of like pre, I guess, peri, and then post. So you can see this, right? So you've got higher rates of asthma, you've got higher rates of various infectious diseases, right? Much higher than the normal, or I would say normal, but I should say general population. And then coming out too, very similar, right? So breathing issues, asthma, COPD. These are average rates, and then this is jail and prison, right? So average and then jail and prison. So you can see much higher as a cardiovascular risk, asthma and COPD, okay? And then speaking on mental health, again, same thing. Yellow is going to be your average, but then just much higher rates, right? Across the board, right? For all multiple and various kind of mental health conditions. Again, same thing, right? So oranges are your average US adult, and then yellow is going to be individuals with incarceration history. Right? Disability is another big piece too, and there's a whole overlay of like homelessness and disability, which I really want to like explore personally. But you can see even a differential here, right? Hearing, vision, cognitive disability. Imagine these folks are in prison, with cognitive disability, right? And then just purely physical ambulatory. And so this is, again, it's data, it's statistics, it's showing the reality and this differential. And so kind of this is the thinking, truly, and even in our clinic, there's different ways to think about incarceration. We have a dedicated clinic that's specifically for transitions clinic, but at any given moment, and I think this is the way to think about it, any average patient you might have may have that prior incarceration history for whatever reason, right? Are there implications of having that prior history? Because truly, right, so these are multiple studies, right? So a high risk of death immediately upon release, but each year that you're served drops your increase your odds of death. So the translation was for every year that you're in prison, you lose 2 years on your life expectancy. So this was a huge paper, I think out of New York, like New York prisons. And then because of this particular overall decline in life expectancy for 2 million Americans, that then led to an overall on the average of the US life expectancy. So imagine that the US is jailing and imprisoning way more rates than all these other industrialized countries. that will drop our life expectancy as a whole. That's just the health of our country as a whole. And then this more statistics here, thinking about people who lacked insurance or lacked healthcare access prior, all of this here, a quarter of these chronic medical conditions never had a prior diagnosis until receiving that potentially healthcare, potentially quality healthcare in the system, with a medical screen, and actually getting, like imagine finding out in prison X condition, Y condition, Z condition, and that's highly prevalent. And then this is just an individual thing where even though there is offered to have some kind of healthcare screenings, and this might be the federal guidelines that are supposed to have that, by report, your average person or 81, a vast majority will say, I didn't see any doctor. I didn't talk to anybody. I didn't get any care, even though technically they might have. Right? So it's a perception thing. And this is what Dr. Howell was speaking about is, conflating like authority figure, like, well, the docs are working in cahoots with the custody. I mean, you can imagine having that experience. And so this was a large kind of summary slide here. So I was gonna do this more like a take a guess. But I think just to look at everything, we talked a little bit about what healthcare looks like, right? And just if you're incarcerated, no privacy, you cannot move around. The environment, you may be shackled, right? And that in and of itself, I mean, everything that comes with that mentally. This dual loyalty concept, I don't know if anyone's ever heard of this, or this is exactly like that feeling. If you're a healthcare provider, who is your, I guess, like, who is your allegiance to? Is it to the patient? Is it to the employer, who might be the local jail? And then your inability, there might be policies that are really antithetical to healthcare and medicine, right? That there might be some local policy that says you're not allowed to prescribe this particular medicine or whatever it is. Can you still operate in that system, or will you just get out? And so,
Jeffrey, just to highlight that, even sort of the point is that oftentimes sort of healthcare providers in correctional settings are in the same unions as correctional officers, which you can imagine sort of then sort of just sort of reifies that dual loyalty explicitly.
And just to speak personally, I think so. I worked in a county jail, which was, we tried to be as progressive as we could. And I think we were independent of the sheriffs, which was amazing, right? So the correctional health services was not run by the sheriffs. And I think that the patients did look to us as their advocates against custody, right? So if they had a complaint or custody did this, or, in our capacity as healthcare providers, we would be able to, hey, let's take this, let's escalate this particular complaint, this particular policy. So I would like to think that my patients saw me as an ally, and not, just another custody person. And yeah, there were instances where you would have to go right up against sheriffs and speak to their policies, speak to their particular behavior when handling patients, even in the clinic. Hey, please remove all these shackles. Can you all please leave? We need some privacy here, right? I happen to be in a relatively progressive place, but there could be many other settings where the healthcare providers would have a different experience and the patients would have a different experience.
And also just to highlight the privacy issue. So when people get medications, it is not true of all. There's some facilities where people can have meds on their person, but many facilities where the meds are given out in a med line. So you just literally stand up in a line every day, and a nurse sort of passes you your medication. But then they'll be like, for people who have like a diagnosis of HIV or a diagnosis of opioid use disorder, everyone knows because like you're on the line to get your HIV medications. And so it's like literally like will be yelled out over, out loud, like everyone sort of going to get methadone, sort of line up now, sort of type of thing. So there's literally no privacy of healthcare conditions. The flip side is with some irony, sort of oftentimes correctional facilities are very like lean into HIPAA as a way not to share information, oftentimes inappropriately. So they're both sort of very freewheeling about sort of privacy, then also try to use the HIPAA to protect themselves as well.
Yeah. Yeah, so this second big portion is just the facility itself, right? So you can just imagine overcrowding, etc. This lack of oversight is interesting. Again, it's just like depends on the facility, depends on who's running it. And then just to go back to this is sort of the prevalence, right? We have various kind of high rates of certain bloodborne diseases. Tuberculosis, that's part of our screening questions, right? Whenever we are doing some quant or PBD testing, you're asking about that as a risk factor, not by behavior, but just by the risk factor itself. TBI, depending on the nature of injury or nature of how someone might have ended up in jail, as well as incidents or treatment by custody or between patients or prisoners, different kind of injuries, and then a lot of this behavioral health, right? The PTSD of the jail experience in and of itself, right? Either pre-existing, acquired during incarceration, etc. So this is just the high prevalence. And think about the overlay that you might have with your unhoused individuals, right? A lot of the same similar behavioral health issues, a lot of the same similar chronic disease issues, uncontrolled chronic disease for different reasons, lifestyle reasons, medication access reasons, the overlay. When we talk about environmental health exposures, that similar overlay, right? Temperature, climate-related health conditions. Yeah, there's a lot of overlap here. So anyway, this is just a kind of similar thing. So we talked about all the environmental factors. This is the kind of institutional policies within a jail itself, injuries, violence, again, between incarcerated or by custody. And then this last piece is interesting in general. Again, where will you end up, or where your healthcare is? A lot of these types of services are difficult, and I think I've heard multiple pieces about someone who's taken from the prison to go to get a surgery at the hospital, right? So then they're shackled to the bed. I don't even know if they're shackled during a surgery, right? Any other patient who's in the hospital post-op or even anything like that is getting visitors from family, and you're not having that with custody, right? Who's sitting in the room with you. So there's just that difference and dehumanization of someone, even if they're not in the facility, right? Even if they're off-site. So yeah, a lot of these pieces could be lacking, right? The idea of advanced care planning, the idea of even having a healthcare proxy. How available is your healthcare proxy or medical decision maker when you happen to be incarcerated? So these are just kind of part of the institution itself. And then this is sort of this rubric that we were thinking about, and I'll just open it all up. I know the type is small, so but this is a paper out of Nature. This is Dr. Lisa Puglisi, Emily Wong, out of the SEICHE Center. And again, just really a summary slide of this pre-incarceral kind of status, right? Socioeconomic reasons, structural racism, educational inequality, all of this kind of has a downstream effect, right? Whether you're talking about therefore limited access to healthcare overall, and then certain behaviors, and then also leading across into incarceration. So anyway, I can't read the whole slide, but it's a great slide. It's a great paper. Really just kind of has that kind of structure of like pre-incarceral health risk factors during incarceration and then post-incarceration. The main thing being these poor transitions, and kind of what somebody does right after leaving prison. So, Dr. Howell, any thoughts on this particular slide? I know it's a big slide, it's a lot of information.
No, I mean, I do think people should sort of follow up on the paper because it is a good way to sort of like systematically go through it all. And I also just want to acknowledge the time that it's 7:30.
Oh, it is? Oh, I didn't even know. Okay. Well, in that case, um, this is speaking a bit about the high death rates post-release, right? So you could just see this number here. And I just want to see if there's anything else. I'm sorry for going over time here.
No, this is really the kind of just so people. This is like the landmark paper, the published by Ingrid Bingswanger using Washington State data that really was the first to document sort of post-released high risk mortality, and they compared it to the general population. The black line, I think, is the during incarceration mortality rate, and the dashed line is sort of the general population mortality rate. So you can imagine. So actually, people sort of while they're incarcerated, their mortality rate is actually a little bit lower than the general population, but as soon as they're released, it jumps way up. And the top, just to highlight the top leading causes of death are overdoses by far the number one cause of death in the immediate time period following release. And then it's followed by suicide, cardiovascular disease, and then some like cancer and homicide are also up there.
Yeah, I think, oh yeah, here we go. Right. So that's what we're talking about. So
in jail, Jeffrey didn't put the paper in there, but we did a paper looking at data from Minnesota, and the release from jail is similarly high risk of death following release. It's not as high as prison, but it's a more heterogeneous population. And sort of to be published, we did try to tease out sort of different populations. And there are people who are, especially the people who are street homeless and who are churning in and out of jail, their risk of death after release is extremely high, sort of much higher than the general population, and they're really the highest risk of having a poor outcome after release from jail.
Okay. And again, just kind of re-emphasizing this kind of, you know, where folks end up, how individuals end up incarcerated, you know, which is and then how at the same, whether they're similar factors, same factors, dissimilar factors, how someone might end up homeless, and also with limited access to healthcare. So again, there is a lot of confluence there based on structural issues within our country. And then within, we talked about all the different pieces of the environment itself, and then potentially the quality of the healthcare itself, good or bad. And then after that, carrying that risk of high morbidity, mortality that we saw. And then also, if you're not having good discharge planning, if you're not connected to a transitions clinic, etc., then it just makes everything that was pre-existing worse. So just a couple things as we've worked with individuals with prior incarceration. Again, this could happen in any clinic setting. This could happen in any random place. You never quite know that someone happens to have that history. But we do try to have some continuity and building trust, just like any other relationship. Asking if someone's willing to discuss, like, have you been incarcerated before? Where are you staying these days? What is your housing? You know, all that kind of, not asking these in non-judgmental ways, but being able to access that information. Because once you have that, then it's like, all right, I may need to do things a little bit differently. I may have a whole other set of resources available for this person. So I do try to ask these questions. It's possible to get medical records usually easily, right? So if you happen to find, this person happened to be in jail for 20 years, my goodness, was there anything that happened during that time? And somebody might say, all kind of crazy medical history. Okay, then try to get those records. Or there might be a completely, it might be a completely kind of non-incidental stay, let's just say. There was a question here from Willow. Is anyone familiar with successful reentry community clinic models?
It's a good plant question, Jeffrey. Just to jump straight.
I didn't plant anything.
I know. Can jump straight to the transition clinic model.
If you want to talk a little bit about it, we'll come back to the slides.
Well, no, I think, I mean, given the time, I think we should sort of just talk about some interventions that have been shown to sort of improve outcomes. Probably the one that's sort of best known to Jeffrey and I is the transitions clinic model, which we've hinted at a little bit, but to highlight sort of what it is a primary care base specifically for people returning from incarceration. And it is also the key component is it's a community health worker model, and sort of every transitions clinic has a community health worker sort of embedded in it who they themselves have a personal history of incarceration, and they help sort of navigate and sort of build trust in the healthcare system. Currently, I mean, this is the most recent map of sort of where the transition clinic models have expanded to. I think the two states to highlight that probably have the most number of transition clinics are North Carolina and California being where they started. But it is a pretty it is an evidence-based model. I've done a couple studies, RCTs, that showed it actually reduced emergency department utilization following, sort of compared just for people who got standard of care following release. And then we did actually a study here in Connecticut that showed people who engaged with the transition clinic actually cost the system less money. So it was actually not just a cost effective, it was actually a cost savings intervention. And then most of those cost savings actually were due to decreased sort of parole and probation violations. So people were going back into the criminal justice system less just because of access to this type of high quality healthcare.
Willow, where are you? What state are you in? What city?
Hi, can you hear me at all?
Yep.
Okay. Yes, I'm a third year medical student at Ohio State.
Out of Ohio State, you said?
Yes, Ohio State.
Yeah, I mean, there are certainly local organizations. If you happen to not have a transitions clinic in your state, many well, I shouldn't say many, but some states will have actually release centers or transition centers. So let's say they serve out the last 6 months, not in prison, but in a city, where they might want to relocate. And during that time, they may still have curfew. They may still have to come check in, check out, but they're going to their doctor's appointments. They may be going on job interviews. So there certainly is, for how cynical everything sounds here, there are discharge planners who are, working on I would say trying to coordinate, prevent reentry, and try to establish patients when they leave to different multiple community organizations. So I don't know Ohio State, I don't know Columbus, I'm not sure what there might be out there, but certainly there are many different organizations, that are helping individuals who are leaving the system.
And the other thing to highlight is there's really going to be a sea change to the next couple of years around reentry and sort of healthcare as people sort of moving out, mostly driven by sort of changes in Medicaid. So Center for Medicaid and Medicare Services it actually put out for states to request that they get a waiver from the Medicaid programs or 1115 waiver, where they can actually use Medicaid to sort of pay for services before people are released. And so I'm imagining sort of it's going to be kind of like 1,000 seeds sort of distributed over the whole state, as about 19 states have applied for these waivers, that there's going to be all these new models coming out and hopefully sort of generating new evidence about how to improve health outcomes for people coming back. So I think the next 5 years, 10 years, there's going to be a lot of new evidence about how to improve health outcomes of people released from jail and prison.
Yeah. I know we're short on time too, and I know we've talked. I'd love to hear like some regional. Have there been anybody who's had successful connections, helping anybody with resources or anything like that? I'd love to hear that. If there was anything, or if anyone else can share out there. But go ahead, Danielle. All right, I see Danielle got a hand raised out there. Or not.
Yeah, sorry, I was just trying to unmute. So with the street medicine program in Knoxville, Tennessee, as far as I know, we don't have any transitional clinics. We have sort of gotten involved in day reporting centers for Tennessee Department of Corrections, and are providing medical care like once a month, trying to increase it twice a month. And it's very well received. But my board is saying, well, we're street medicine. This isn't really how do you justify giving resources and our time because this isn't really street medicine. But in my mind, it's transitional housing, which we do have under
Yep.
our purview. So, any ideas you have about how to keep my board convinced that this is the right thing to do?
Interesting. Um, I can't always say it's a financial question, but I think like a lot of the work is around, okay, well, hey, if we were able to do this and spend this, then this created some kind of lower cost, which is a terrible thing to measure, but I don't have any other strategies
Yeah,
really.
Danielle, I don't have a perfect way to sort of spin it for your board to sort of acknowledge, but I think you're gonna see inherently sort of people who are showing up in that type of center are going to be disproportionately compared to the general population, people who are unhoused or even sort of on the edge of being sort of street homeless, and it could even think of it a preventive way. But I don't have a great way to spin it because you're right, like it's not the street, it's a different place, but hopefully people can see that prevention and sort of getting people before they're really on the street.
Megan,
Yeah,
can you
I'm
share?
glad to hear about transitional clinics. Maybe I can get somebody to start that.
Yeah, no, it's a great opportunity. I will say it's not easy to start a transitions clinic. Most of them are based in FQHCs, so it is one of the places where it is supported. And I do think these 1115 waivers are going to make it. And actually, the transition clinic model was quoted by CMS as sort of a model way to try to improve care for this population. So you can even quote CMS on that.
There really is no other nationwide network aside from Transitions Clinic, and I'm not even just because I'm a fan, but I mean that's the truth. So it is their websites. You have a QR code there. It's transitionclinic.org. You can hire them for a working group, for consultation and setup and program development, everything like that. Megan, can you share a little bit about what y'all are doing in Pittsburgh?
Sure. Hi. So we have a law practicum through the University of Pittsburgh's School of Law, and they've been joining us on street rounds, the students. And so, for example, on Thursdays, we set up at the library, and folks are able to come pop in, talk with the doctors, grab some snacks. But we also have law students, and they're not providing legal advice, but they're helping folks get familiar with free or low cost legal services in our area. And we've just seen such a building of trust among folks. It's been a really, really positive experience. And so we're really excited. We just went through our second cohort of law students who have joined us. And then there'll be 6 more joining us in the fall, and we can't wait. They also do they did final presentations on the importance of like medical legal partnerships. And yeah, it's been really neat to learn from folks.
That's great to hear, Megan. We're huge fans of medical legal partnerships, MLPs here. I mean, we are lucky that our transition clinic does have a MLP where similar to what you're describing, they do actually provide legal advice sort of under the guidance of a Yale Law School faculty. But sort of MLPs, and we are lucky that our first grant we did embed sort of that lawyer in our street medicine program that we're hoping to build that out. But it really does seem like such an opportunity to address oftentimes not criminal legal needs, but social legal needs, or sort of like employment stuff, benefit stuff, sort of getting ID stuff that are really sort of impact people's ability to navigate the world and housing. Yeah.
Danielle, you had a comment? Or maybe that was a prior raised hand.
Yeah, sorry.
Okay. All right. Okay. Well, I don't think we have a lot more other slides here. Thank you for putting up the documentary. Someone had a link in there. These are excellent, and they're all available relatively easily. So, just highly recommend all of these. and there's a whole bunch of references here. So anyway, if anyone has the time or capacity, we do have a survey for this talk. We'd love to hear your thoughts on it, and maybe I'll try to throw it in the chat too. Any other final questions or discussion points? It seems we're hopefully we're.
Correct. My email is benjamin.howell@yale.
Oh goodness.
That's okay.
All right.
And yeah, definitely.